Okay, perfect. So let's go to Pune. I think they're ready for us.
It's on.
Dr. Duggal and Dr. Mehta, it's Saurabh Gupta and a distinguished panel. Welcome.
Who is the
Can you hear us, sir?
Yeah, we can hear you.
Well, welcome. You're live. So we're excited to see
we'll
what
give
you
the
have.
short history of the case. Subhat, can you give the short history of the case?
I'll come out, I think.
Known case of hypertension, just presented with the complaints of chest pain.
Can't hear you. We can barely hear you. So can you do the case presentation perhaps with another mic?
Am I audible, sir?
Yeah, better. A little better, but not great.
Just change the mic here.
Am I audible?
Yes. Yeah. Go ahead, please.
So 56-year-old male patient with the known case of hypertension presented with complaints of chest pain. 1 day prior admission to the
Do we need to change the catheter? Catheter change karna, catheter is okay.
Previous slide.
On arrival in emergency, ECG done with suggestive of increasable MI. And the ST segment elevations in lead 2, 3 and AVF.
You're showing the last slide. Can we have the first slide?
To the beginning of your slides? This is we're seeing the last slide.
So basically, it's a 56-year-old hypertensive patient, came with inferior wall MI, STEMI. By the time he had pain for 1 day prior to the admission, on admission, he outside ECG showed clear-cut STEMI in inferior wall. But by the time he reached the hospital, ECG was, more or less settled down. Pain also subsided. We did his echo. Echo showed ejection fraction about 50%. And we took him for actually primary angioplasty. When we did his angio, can we have the angio run, please?
Just I'll talk about it.
The angio run. So, okay, I think you directly are seeing the right coronary artery. I mean, are you seeing the right coronary artery? Or
yeah.
Yeah. So basically, on the left system, there was about moderate calcium in LAD, 50-60% disease in LAD. There was about 50% disease in circ-OM. But the culprit was right, which was kind of a super dominant with significant calcium. And as we had a TME3 flow, we didn't proceed with PAMI. We didn't proceed with stenting at that point of time. We kept patient on heparin antiplatelets. He had some issues with GI, so we got his endoscopy done, had some mild erosion that was tackled for 2 days, and today he's here for plasty. I mean, the plan is to go ahead and do rota first. So Dr. Duggal, you want to add on something?
So as you see, there is a dense calcification, and in angio also we thought it's a tram trail sign sort of thing, but there were 2 nodules, one in the proximal just after the first bend, and then the second also showed a nodule. So the first was little eruptive nodule, and there are 2 nodules which we'll show you in OCT, which we had to take with a guide liner, and we had to dilate it, pre-dilate it with a 2 millimeter balloon before we could take an OCT catheter.
So do you want us to freeze the angio to have a better look at the angio first?
No, we see the angio. So maybe if you wouldn't mind showing us the OCT run that you did, Dr. Duggal, after.
Yeah. So I think Dr. Ankush would be showing us the OCT run. OCT, actually, we tried taking the catheter without doing pre-dilatation. We thought, let's see where we are and what is the calcium score. But then, unfortunately, we couldn't take anything down. And we had to do pre-dilatation with 2.5 balloon. And the first OCT, Dr. Ankush?
So, what do you think of changing to an active guide support now at this stage? Seeing these 2 calcific nodules, I think you're going to have a tough time getting your devices down also.
No, but with rotational atherectomy, active support may not be required because we are planning to do a rotational atherectomy first. And let's see how it does with the rotational atherectomy. And then first we'll talk about the OCT, and then we'll show you what we have done.
So in fact,
hello. Yes. Can you see the OCT image?
We can see the OCT.
But we can't hear you.
So this is the OCT
Can't hear you.
Can't hear you.
Can't hear you that well, but we see the. No, that mic seems to be not.
Am I audible now? Can
Faintly.
speak louder. Okay, so this is the OCT run of the RCA. If you can see on the L mode, you will be able to see two nodules. One is the distal nodule that was visible there on angiography, and
TCT
another one is
heparin.
the proximal nodule. Let me show you the run of the OCT. If you'll appreciate in the distal nodule, it was a kind of eruptive nodule. So it is after balloon dilatation, but you will appreciate the different morphology in both the nodules. Can you see? This is a nodule which you can appreciate in the L mode, and in the cross-sectional view, can you see this is the eruption? So likely that inferior wall MI, that acute coronary syndrome was likely because of this nodule. And if we go up to this, after this nodule, can you see 360-degree calcium? The depth of calcium was around, around 10 mm. And if we go to the proximal nodule, so can you see this nodule? It's a kind of a stable nodule with a thick cap over it. There is no, eruption over it. And when we measured the length of the total lesion from where started the run, it was around 48. Proximal reference diameter is around 4.4. Distal reference diameter is around 3.7. So seeing the calcium score is 4, and we know that in this kind of calcified coronary artery, we need a modification device. Now, Dr. Duggal will tell you what we did
Yeah,
after
so
this.
we took a extra support wire because we wanted to be, correct it, purchase the lesion, which is nodule is on the inner surface, the proximal. So we took a extra support wire and did burring with an extra using a 1.75 burr at the proximal portion. Can you show that, Anju, please?
So the minimum diameter I could see was about 2.5. So why do you want a rotor? Why can't you take an IVL balloon straight away?
So as we said, we couldn't even deliver the 2 mm balloon initially. It was difficult getting into the artery. There was so much of calcium, we couldn't even deliver the normal balloon 2 mm.
See, that proximal nodule won't allow anything to go. So after burring, we could take after we did the 1.75 proximal, then we changed to a smaller burr and did the distal with the 1.5. And now we will show you the OCT after you see how the result. After proximal, we did it with 1.75, distal, we did it with 1.5. We'll show you the.
And why did you do that, sir? Why did you change the 1.75 to 1.5?
Because the distal was smaller and it was not going in. So we thought we'll do it with a smaller and then upgrade it to again to 1.75. So I'll just show you we'll show you the OCT, what we have done up till now with the rota, and then we'll take next step forward.
Dr. Duggal, would the 1.75 burr not go past the distal lesion? Is that what happened?
Yes, it was not going. So
Uh,
then we changed it to 1.5 and did the distal one. Proximal, we could do it with 1.75. Distal, we had to do with 1.5. And now we plan to do the distal one also with 1.75. So this is after doing rotational atherectomy. We'll show you the OCT and then we take a next step forward.
So there is no confusion that this patient requires calcium modification. Score is 4, and it has got 2 nodules. As we all know that calcium nodules are the one which are very difficult to modify, and they all ultimately lead to underexpanded stent. So let me show you. Can you see the OCT run?
We just see a
Yeah, we
still
can see.
image.
Okay, let us see what happened after modification of the proximal nodule with 1.75 and distal with 1.5. Let us see. So here is the distal from we are coming to the distal nodule. Here the MLA it is showing is 5.4, and this is the proximal part. So it has this 1.5 has not touched anywhere between 2 nodules, but yes, definitely it looks like that it has modified the proximal nodule. Maybe the wire bias has helped it. I'll show you just now.
Let me ask the panel what we think of this strategy. So
We'll go to 1.75 sir.
Hmm.
करना पड़ेगा. चलो, ये दे दे, corsair.
Corsair.
In acute MI situation?
yeah, so the question from our panel is, how comfortable are you in general in the setting of an acute MI rotational atherectomy?
No, but when you are pushed to the wall and then when we have such a heavy calcium and we cannot deliver
See,
even
there is a lot of data from South Korea in acute MI rotational atherectomy, and the results are compared to non-acute MI situation, the results are good. So that was the only thing. Otherwise, we will not be able to do anything to the lesion. And so only thing is we have to be worried about slow flow, no flow, and ST elevation during the procedure. It's a more complicated procedure, but people have done it. And there's a lot of Korean work on this, on doing it. So we thought we'll go ahead because that is the only thing, because his RCA is the only main artery which has a problem. The LAD is not much. So taking that into consideration, we thought we'll go in for rotational atherectomy.
So
So
can we ask
Dr. Duggal and
panel
Dr.
that
Mehta,
Yeah.
Dr. Duggal, this is Dr. Shashikant with you. Just to give a provocative question, so you have a situation with a recent ACS, and it's a very large vessel. We just finished a session on orbital atherectomy for this patient. How do you think orbital atherectomy will do here? Rotation, then lithotripsy.
It is a very good modality here, but the only question is distal lesion we won't be able to do. Proximal we could have done a very well with orbital, but distal, which was, if you see the first angio, it is almost like 100% occluded, that calcium. So keeping that in mind, probably rotational atherectomy would be a better choice. Yes, orbital for proximal, we could have done it. And here we could have done it with a 1 burr here instead of escalating to 2 burrs. Orbital atherectomy,
Cranial.
1 burr, all the artery size. We could have done, but distal crossing would be impossible. If I show you the angio film when we did it, it is absolutely, after even the OCT catheter wouldn't go, after dilatation with great difficulty, using a guide liner, we were able to take it.
And moreover, here we use the benefit of imaging also. After doing imaging of the RCA, we know it's a eruptive nodule that has caused the ACS, number one. Number two, there is no intraluminal thrombus. We know that this coronary artery will not be causing so much of problem as far as rota ablation is concerned. That is how we can use imaging in this setting also.
Ankush, in the post rota OCT, can you show us what you have achieved?
So if you can see, this is a proximal nodule, and this is the wire where the OCT, catheter is there. So likely, if you can see, can you see this is the completely circular, calcium bed over the nodule. So likely the rota ablation that we have used 1.75 where it has, very nicely ablated the, calcium here, and it has make it a, can you see the sharpen end of this lesion? Can you see this?
Yeah.
So with imaging before going for rota, we knew that likely we'll have a benefit of this wire position at this point, that we may get some modification. And if I can see the MLAs at both the nodules, there is some increase in MLA, number one. Number two, as you all know, that with this kind of calcium, without doing ablation technique, we will not be able to expand our stent, and our long and short term outcome will not be good. So imaging in ACS setting, we knew that it's likely that a rotational atherectomy or ablation technique will be stable in this particular artery.
Great. Can you show me the modification done in the distal nodule?
Yeah, I'll show you.
So at this point of time, what do you feel? Should we upgrade it to 1.75, or is there any, should we do cutting balloon? Because probably we have not done anything to the both the nodules. So what does panel feel?
What is the question?
No, should we go ahead and upgrade balloon, the rota to 1.75, or we should do cutting balloon with 3.5?
I think you should go for an IVL.
So yeah, absolutely correct, sir. So we also thought of that the first choice as IVL. But as you all know that in this kind of scenario where the taking a 2.5 normal semi-compliant balloon was very difficult, and we all know that IVL has got a crossing profile of around 0.04 to 0.043. So I think we felt that that at this position that before IVL, or before any, balloon, cutting balloon or scoring balloon, ablation will help us taking all these, devices inside.
Okay, so we'll let you do this part, and what I want to do is break away for a few minutes, and then we'll come back and join you in about 5. Okay, let's go back to Pune with Dr. Duggal and Dr. Mehta. So we're back and just checking in to see how things are going.
So can you hear us?
We can hear us, and we have 5 more minutes before we have to break off.
So we have done rotablator with 1.75 again, and now we are here with we're just going to do OCT again.
So one thing we just want, can you see the OCT image?
Not yet. Now we can.
Yes.
Okay, so here, if you can see, this is the pre-rota, that is by 1.5 and 1.7 in the proximal nodule. If you can see, the MLA was 5.12. After this rota ablation, I'll show you how that smooth surface of that calcium has done, and I'll show you the MLA. The MLA has increased from 5.12 to 7.09. Can you see this? This is the proximal area. So it has done some work. And now we'll show you OCT after ablation with 1.75. And after that, our plan is to go for cutting balloon and placement of the stent. After seeing that calcium has been adequately, modified.
Did you 1.75 but go up to the distal lesion?
Yes, we'll just show you. Can you show that angio, previous angio?
Second.
One, two backs, another one. Now you see this is 1.75. No, forward. This is 1.75. Go next. Here you see. Go play. Na? Yeah, here we have done multiple specking movements, and you can cross the lesion distally till the distal. The earlier we had done in the PLV, this time we have done in the PD to change the axis of the rota, and we have done in both the vessels now. Keeping the wire in the PLV, keeping the wire in the PD. Now we are taking a Sion wire and we're going to do the OCT. So multiple runs and even a polishing run has been done. And now let's see how's the result. And then we take the next, whether to go for IVL or a cutting balloon.
So by that time, can we ask a panel what could have been the different, modification strategy if anybody else would have used?
Let me ask our panel on what we're thinking. So,
I think other than the thrombus in the RCA and what was the compelling reason to take up the patient so early for a procedure unless he's having severe post-MI angina?
He was having angina.
Yeah, that's what, because we didn't know that.
That was the reason.
And I would have loved to see his left coronaries before we started discussing this case, because that would be important, how much,
that is
because
not,
if there are very critical lesions on the left side,
no, this is not
we ultimately get into a slow flow or a no flow situation with such a huge RCA. I would really be, kind of very apprehensive to do it with such a thrombus.
Absolutely correct, but in
left
the
side is very important to see in such cases.
We'll show you the left side, but
if you have shots, we would love to see them.
We can just put it. See, the reason was even in the OCT there was not much thrombus, so that was another good point that we thought we will be able to go. And this is the OCT we are doing again. Can you show the previous one, the angio? Angio. Just go to the angio.
So Dr. Duggal, we'll maybe quickly see this OCT run, and then we have to break off to our next site, and maybe we might be able to come back to see the final results. So if you could show us this OCT,
yes,
I think we'll break off after that.
Yes, we'll just show you the run.
So this is a typical example of heavily calcified, with nodular calcium lesion. Ready?
एक मिनट रुक जा.
ये नहीं 20 की ना. I am comfortable with 20.
Give some more contrast.
Give it 20 here, 20 cc. Yes, we will repeat it. Should we repeat it?
We can get a good image.
Yeah, this is the left system. Can you see it?
We can.
Yeah. So you see there is not a significant disease in there. There is a calcification in the LAD, and the circ had got a lesion in the, you see, this is the LAD. So keeping that in mind, we thought we can go ahead with the RC because that is more important here. The left system is quite okay, except for my
left system is not bad.
Yeah, and the LAD is a reasonable size vessel, covers some of the apex. So I think I agree with your strategy of treating the RCA, especially if he was having post-infarct angina. And it seemed like he was about 3 or 4 days after his MI anyway. Okay, so let's look at that OCT run real quick, and then we might have to break off.
Babu, go back.
So can you see this OCT run here?
Yeah.
We
Yeah.
can.
So let us see what happened to the proximal nodule. So this is the proximal nodule.
Proximal nodule, we are happy.
Yeah. So proximal nodule, you know that MLA has increased. Just let me show you. That MLA has increased to 7.64. Let me show what has happened here.
15.
Can you see the amount of destruction that there is again smoothing? This time the wire was slightly away from that cupping, so it has modified the other side. Number one. Number two, let us go and see what has happened to the distal nodule.
We can show them the angio also.
Can you see this distal nodule?
We can.
There's thrombus there though.
Exactly. So this is what is the heating effect of rotablation. So whenever we do rotablation, it causes some heating and platelet aggregation, and this is a typical kind of white thrombus that we see on OCT after rotablation. This is a typical white kind of thrombus that we see. Can you see this?
Perfect. Well,
Yeah.
we have to break off to go to the next slide, but I think thank you for sharing those
So
images with us.
the last image, we'll just show you the angio image here after 1.5 and after 1.75. Can we run the video?
Yeah, perfect. We see it. So there's still good flow, and the lesions definitely look a little better. And OCT showed that you have modified the plaque a little bit. So is your strategy now to just balloon dilate and stent?
So
Yeah.
would you do cutting balloon now, or you just do NC balloon then come back and just do stenting?
I think I would just do a non-compliant
NC.
balloon and then go ahead with PCI, especially if it expands. Well, we do have to break off. So thank
Okay,
you very much, and great work, great job. Congratulations.
Thank you.
Thank you.
Can we go to the
No.
Pune site, the Jehangir Hospital with Dr. Duggal and team?
Yes.
Hello, we're back.
Yeah. So we did a rotational atherectomy for the distal also with a 1.75 bar.
And that's where we had left you. I think we'd
Yeah.
seen the IVUS after the 175 bird distally.
And this was followed by balloon, NC balloon at high pressure, and then 3.5, and then we stented distally with the 3.5, 38, and proximally with 4 millimeter stent. So I'll show you the angio and the OCT images.
So in fact, after doing 1.75
Thank
and
you.
doing high pressure balloon dilatation, we had to take guide plus 2 to deliver
Yeah.
all the gadgets, even balloon, even stent and everything. And then that's what we thought. IVL tracking down across this calcific artery would have been difficult. So we avoided doing an IVL in this artery particularly.
Last shot, dekha na? Just show the
That's
last
the reason
shot.
I think I initially told we thought we should use a active guiding, because it's very difficult to push the devices down this
Yeah.
vessel.
Next. So this is the
This is for
this is the result you can see, and then we did OCT, which will Dr. Ankush will show you just now.
So
Post dilated with a 4 millimeter balloon inside, and this is the final. Just go last.
OCT run dikha ke we'll do post dilation.
Just go. So this was the final picture. It's a very large artery. You can see the huge PLV PD, and now we'll show you the OCT.
So can you see the OCT image?
We can.
Okay, so this is the typical example of eruptive nodule causing acute MI. So this was the distal nodule where we started with 0.78, and after 1.75 it was 1.49, and in the proximally it was around 7. And let me show you what happened after putting a stent. So we placed 2 stent, 3.5 38 distally and 420 through proximally, followed by post dilatation with the 4 mm balloon. So can you see the OCT run after putting a stent?
Yes.
We can.
So distally there was some malapposition. There was no stent, edge dissection. Expansion was 85%. And I would like you to see the run at distal nodule. The whole of the artery is circular. Can you see? This is the distal nodule area. So after putting stent, after rotablation, This is the indirect evidence that this was a eruptive and soft nodule that get settled with the rotablation, pre-dilatation with the NC balloon, and it gave us a circular coronary artery, and this was the likely cause of acute myocardial infarction. And let me show you the proximal nodule. So the proximal nodule, OCT wise, it was a stable nodule, and that is why we didn't get that kind of spherical artery. Can you see? This is the proximal nodule. Here you will see nodule that even after 4 high pressure pre-dilatation and post-dilatation, there was some nodule that didn't get compressed. So this is the indirect evidence among these 2 nodules. Distal one was the cause of acute myocardial infarction. It was soft. It gave us a idea that this was the cause of myocardial infarction. And distally we got a minimum stent area of 9.12. From 0.78, 1.49, it's 9.12, and proximally the minimum stent area is 12.86 with expansion of 85%. And with this, we can expect that patient will have a good short as well as long-term outcome.
Now that's a
One
very
question.
good result. Thank you for
Yeah, thank
sharing
you.
that. Very nicely done.
So one question, do you think an IVL would have made a difference in the proximal nodule?
So after the end of this case, we strongly feel that the amount of struggle that we had with the proximal nodule, distal nodule,
we wouldn't be
and
able
what
to
we
take
saw
it.
with the rotablation, without ablative technique, it would not have been possible.
Finally.
Yeah, it's not possible because the tracking, the profile of IVL is much bigger as compared to non-compliant balloon, and our non-compliant balloon was not even tracking down the proximal as well as the.
One last question to me, Duggal, I want to ask because it's eruptive nodule. So we are expect the TLR and the TVR and MACE will be higher compared to the non-eruptive nodules. The
Yes.
long follow is demonstrated.
Yes, yes.
Yes, this is the typical character of eruptive nodule. Acutely, they settle down easily, but they come
They
back
may
even
come
inside
back
the
again.
stent
Yes,
also.
yes.
But I think, remember, these are all observational data. And so the reality is that if you present more frequently with an ACS compared to stable, you're going to have a higher rate of events later. So while we like to ascribe it to the nodule itself, it might just be the protoplasm of the patient. I think similarly, the question of IVL versus an NC balloon, the IVL data on nodules is all observational only without a control arm. We have no idea what the natural history of it would be if you did something else, exactly like what you did, which was rotoblator, if you did an NC balloon, if you did a cutting balloon. So it's just a big caution you have to take when analyzing the data. It's not to say it doesn't work. It's just make sure you're a little bit more circumspect about the conclusions.
Perfectly, perfect.
Thank you
Well, this is
very
a great
much.
job. Very
Great
nice.
job.
Thank you.
Thank you very much from Jehangir Hospital, from the team of Jehangir Hospital.
Thank you, sir.
Is TCT. Yeah, thank you.
Thank you.